So I'm Ethan Short. It's nice to meet you.
Yeah, great to meet you too, and thanks for making contact.
Absolutely, absolutely. It is bright and early here in Louisville, Kentucky. The sun has yet to rise, and my understanding it is getting kind of late for you. Where
Yeah,
exactly are you?
yeah, so I'm in Sydney, Australia, about 8:30 in the evening, and we're still in winter here, so yeah, it's pretty dark by 8:30 in the evening.
Yeah. Okay. Nice. Yeah, it is. Been about 90 degrees plus for the last most of the last month for us here in Kentucky. So
Mm,
I'm not too mad because I'm sitting out behind my house in a shed, aka my office.
mm.
Somebody get this guy some help!
So Al Capone is one of the most famous gangsters in the history of the world. He died at the age of 48 after in his 20s contracting syphilis from a prostitute. Now, this was after the discovery of a causal organism for syphilis, but Capone was reportedly so ashamed that he never sought treatment for it. And the reason why I bring this up is because Capone died in the 40s in prison, and it probably wasn't quite well known enough at the time. So the causal organism was discovered in the early to mid 1900s, the first decade of the 20th century. And the effective treatment came maybe within the next 10 to 15 years. But I would assume that because they didn't have TikTok and social media, they didn't have the internet, that a lot of this information wasn't widely known or available. So Capone gradually, as that syphilis virus primarily infects the genitals, secondarily infects the skin, causing lesions all over the skin, though that process can take months to years, and eventually goes to infect the brain and starts to cause behavioral changes. Starts to be a contributing factor to that person having psychosis or cognitive decline, aka dementia. So, why am I telling you this story? Because it is an example of a medical or a neurologic condition that is masquerading around as a psychiatric problem. And I think this is probably a lot more common than we give credit for. So, way back in the day, dementia itself, things like Alzheimer's, would have been considered psychiatric because we did not understand them to the degree that we do now. And I will say we still don't understand them to a full degree. But we understand that when people start to display those signs and symptoms of dementia, it's not that they are having this primary psychotic condition. It's not that they've lived a life of sin and that's why they're developing memory loss and behavioral change, et cetera, et cetera. There are so many different causes historically and into today where something that is requires a medical treatment or a neurologic treatment, people are being put onto a psychiatric unit, which then leads them to get a psychiatric treatment, a neuroleptic like an antipsychotic or a mood stabilizer or a benzodiazepine. Treatments that may have a role in primary psychiatric conditions, but there is this massive differential diagnosis for medical causes of altered mental status. Some of them are more obviously medical than others. Things like hepatic encephalopathy. Somebody's liver doesn't work well and ammonia builds up in their body, and eventually when there's enough ammonia it starts spilling into the brain, causing weird and wacky behaviors. You've got hypoxic encephalopathy, people who overdose on, say, an opiate, but they don't quite stop breathing in total. Maybe they breathe 3 or 4 times a minute, and they start to deoxygenate parts of their brain because you only have so much oxygen to get out to your tissues. You can have metabolic encephalopathy, where you have some sort of electrolyte disturbance, some sort of derangement that then leads the person to become altered in that fashion. Uremic encephalopathy, the kidneys stop working. You cannot get rid of those toxins. And you have what's called uremia, or the buildup of, again, nitrogen in the bloodstream. Certain withdrawal syndromes, certain intoxications. You can have a closed head injury where there's not an obvious injury on the exterior, but the person's behavior becomes significantly altered. Hyper and hypoglycemia, or lower high blood sugar. You can have med interactions. You know, they used to call syphilis general paresis of the insane. And it was first recognized in the 1490s. Between the 1490s and the early 1900s, it was a psychiatric condition. When we don't understand why something's happening, it gets dumped into the field of psychiatry. Now, we test anybody who has any decent reason for having contracted syphilis and presents with altered mental status. It's a very easy blood test to decide whether or not somebody has syphilis as the causative factor there. But back in May, when my sister-in-law called asking about her boyfriend, my longtime friend from high school, and why he was acting altered, the alarm bells immediately started going off. He did not have syphilis, but he did end up contracting one of the most occult diagnoses or conditions that I know of in all of medicine. It is a condition where I have seen patients being dropped onto a psychiatric unit for treatment with an antipsychotic, despite the fact that they have an infection in their brain. My friend got a likely viral encephalitis, totally out of the blue, very little warning, with prominent behavioral change. It was an extremely scary, frightening time for everybody involved. Actually, I would say for him, it wasn't all that scary or frightening because he was completely altered. But we didn't know what was going on. You see a prominent behavioral change, and it's like the doors to that person's conscious brain, or the conscious parts of their brain, are totally closed. That's what prompted this video. Now, Alex has made good progress in his recovery. He had very rapid resolution of his symptoms once the appropriate treatment was started. But to me, it's a foreboding that my job as a psychiatrist, our job as the field of psychiatry, primarily, first and foremost, is to identify these people who are dealing with a condition that is not related to primary psychiatry, and make sure that we screen that out before we immediately jump on the idea bandwagon that this is primarily a psychiatric issue. So it takes a lot of skepticism, a lot of questioning of your own thoughts as well as other providers' thoughts in order to arrive at these things. Without further ado, I want to start with this 3-part series on encephalitis. First with an Australian expert, Philip Britton. We'll do our first episode talking with him. The second episode, I'm going to do my first patient interview with Alex to have him tell us his story. And then lastly, I will bring in my good friend and medical school classmate who is now a child neurologist, Jamie Shoup. I'll bring him back to talk a little bit more about encephalitis and some other topics. So I hope you enjoy. And I will say in the first video, I do apologize, but my part of the video cuts out. So if you just see me sitting there with a face, it's because my video just isn't working and I couldn't find another one. So apologies for that, but hope you enjoyed the series otherwise, and hopefully it helps to illuminate that there are a lot of medical conditions out there potentially masquerading as psychiatric conditions. We will never catch all of them, but our job is to be aware and open to that possibility and make sure that those patients who, if they're not responding to typical psychiatric treatments and they've already, or if they haven't had a proper or full medical workup, or if there's just other factors that just don't seem to point the provider in the direction of a primary psychiatric problem, hopefully this helps to make sure that some of those folks get the workup that they need and that they deserve. Thanks for listening. Thanks for watching. Hope you enjoy and appreciate any and all feedback as always. So, Dr. Britton, the impetus for me doing this is actually because I was sitting at home and my sister-in-law called me she lives out in Denver, Colorado, to tell me that her boyfriend, about my age, about 35, was having some really odd behavior. And I'm going to have him on to give kind of a patient perspective within the next week. So I don't want to give up too much, but he ended up having pretty much, I'd say maybe not exclusively, but primarily behavioral symptoms. Had no insight into the fact that his behaviors were off. And luckily ended up getting to the hospital, even though he didn't realize he needed to go to the hospital, and got pretty rapid treatment with a pretty rapid recovery. Ended up being diagnosed with most likely a viral encephalitis. And we could talk a little bit more about why I think it was, primarily why I think it was a viral encephalitis is because he broke out in a shingles rash the day that he came home from the hospital. So it was a little too coincidental for me to think that it could have been anything else at that point. But it really got me wondering, because this is a topic some of my cohorts in my psychiatric residency and I had talked about, these people getting missed and ending up on a psychiatric unit instead of getting the appropriate neurologic workup. So that's kind of the impetus for reaching out to you and trying to learn more and educate my listeners and viewers a little bit more about this problem.
Yeah.
So why don't you, I guess, first just kind of give us a little bit of background on your professional experience, education, and kind of what you're most passionate about and interested in at this stage in your career.
Yeah, thanks very much. So, look, I'm a pediatrician by training, specialised in infectious diseases, and went on to do a PhD in children and encephalitis, particularly understanding the burden of a disease at a population level. And I'm back in clinical practice mainly now, but continue to run national surveillance for both encephalitis and myelitis, or inflammation of the spinal cord in children across Australia. And so, yeah, spend a fair bit of my time thinking about these infections of the brain and what they do to children in particular, and how can we improve our diagnosis and management of those conditions. That's kind of my major area of research activity. I also do, as many of us have, infectious disease people have done a reasonable amount of work on COVID over the last a few years, and in fact, we're just putting together a bit of a national summary of the way in which COVID can affect cause neurological syndromes in children as well at the moment. So yeah, that's kind of my background in pediatrics, infectious diseases, and particularly neurological infections.
Okay, and I saw from a couple of different websites that you are based at the Children's Hospital at Westmead, and then also says that you co-lead the Pediatric Active Enhanced Disease Surveillance, or PEDS or PEDS network, based at the National Center for Immunization Research and Surveillance.
Yeah, that's right. So they're my major affiliations. I also work with the University of Sydney in teaching and research as well. So yeah, based in Western Sydney, but really with a national network of colleagues in infectious diseases, vaccinology, pediatrics. Australia's a much it's a very large physical country, but a relatively small population country. So the population of Australia is about 25 million. In contrast to the US, about 350 million. So much smaller than the US, which means we don't necessarily have the frequency of some of these rare conditions in the Australian population, but we do have the benefit of being able to pull together a national network. So we cover almost all of the major children's hospitals in Australia contribute cases into this network that we run our studies from.
And that population difference almost didn't prevent you all from taking more golds from us in Olympic swimming. So that's pretty impressive when you consider a tenfold difference in population. So
some source of national pride, Ethan. That's right. Yeah,
yeah, absolutely. How did you get interested or into researching encephalitis?
Yeah, look, that's a good question, and like a lot of people in life, some of these things aren't by design. I got to the end of my clinical training, what in America would be called your clinical residency, was qualified as an infectious disease pediatrician, and had planned to go into a low and middle income country and actually work in tuberculosis in children, of all things. But for several reasons, that wasn't going to work out, and I was a little bit at a loss. And one of my senior colleagues at the time, her name's Cheryl Jones, had an interest in this area but hadn't really been able to get a project going. So said to me, look, like a lot of these things, I can fund you for 6 months and then you've got to get your own funding, but let's see if we can do this. And so we worked to set up this network and move into research in this area in 2013. And I've been at it ever since. And in fact, a bit of an anecdote, one of the reasons I guess I stuck with it is very early on in my doctoral studies, we had a young child come into the Children's Hospital at Westmead, and within 24 hours they'd passed away. And the story was very striking. This was a essentially well child, had a bit of a cold. Mum, stayed at home to look after this child, put them on the couch in front of the TV, with some simple pain relief and fluids. Came back an hour later and the child was unconscious. Brought them into hospital, and 24 hours later they had died. And this child had a very fulminant brain disease associated with influenza called acute necrotizing encephalopathy of childhood. And this was one of the most striking, fulminant, tragic kind of diseases I'd seen in my entire training. And in some ways, it's stories like that that have really kept me in this space, because for a lot of these very aggressive diseases that cause, both child death and disability, we still don't have great answers and still don't have great treatment. So that's kind of what keeps me engaged, is we should be able to do this better, and I hope we will be able to do this better, and if I can make some contribution to that, that'd be great.
Yeah, absolutely. I mean, it is a major theme of the podcast to try to appreciate the nuance in what we do and appreciate all of the uncertainty and the unknown that exists. Most of the experts openly acknowledge all of the things that we don't know. whereas I find some others maybe try to fill in the gaps with, I don't want to call it misinformation, but trying to sound like they know everything about that topic as opposed to appreciating that uncertainty and that unknown. So can you just tell my viewers, listeners, kind of what encephalopathy and encephalitis are in general, and what the difference between the two is?
Yeah, good. So encephalopathy, as you say with a soft C, we use a hard C in Australia, encephalopathy.
I like that better, actually.
Yeah, well, we would say that's how the Greeks would say it, encephalopathy. Anyway, what's that? That's defined really as altered mental status, and altered mental status can be an altered level of consciousness, the decreased level of consciousness, change in personality or behavior. That's fundamentally what encephalopathy is. It's when the brain's functions are impaired such that you see that work out in consciousness, personality, and behavior. In contrast to that, encephalitis, you might say, is a subset of that. Encephalitis is when encephalopathy is caused by inflammation of the brain, in contrast to, say, caused by a vascular injury, a blood flow injury, which is what stroke is, or a traumatic brain injury where you get encephalopathy, but it's a traumatic thing. And so encephalitis is when the encephalopathy is caused by inflammation of the brain. And about half of the time in children, maybe a little bit more in adults, about half of the time that's caused by an infection. And about a third of the time, a quarter to a third of the time, it's caused by an autoimmune or immune-mediated mechanism. And then the rest of the time, we don't know what causes it. And in fact, if you went back 15 or 20 years, people used to say 50 to 60% of encephalitis in adults and children we didn't have a cause for. Now, over the last 20 years, with a fair bit of work in this area, some improved diagnostics, better understanding of the condition, it's more like about 20% we don't have a cause. And somewhere in the middle there, we've also come to understand that there are different kinds of inflammation of the brain. So a classic viral encephalitis occurs when the virus infects the brain structures itself, and the immune system responds to that, and the combination of the virus infecting the brain and the immune response causes the encephalopathy. And the kind of typical cause of that is a virus called herpes simplex virus, and the disease that it causes, herpes simplex encephalitis. We now know that there are some conditions, particularly in children, where the virus doesn't infect the brain directly. What it does is it infects the body, causes an inflammatory response in the body, that then the inflammatory response in the body can affect the brain, even though the virus doesn't infect the brain directly. And we call those infection-associated encephalopathies. So, these things get more complicated as we try to understand them better. But fundamentally, encephalopathy is brain dysfunction. Encephalitis is when that brain dysfunction is caused by inflammation of the brain.
Yeah, and I have been trying to educate as many of my colleagues, especially where I'm from, about the risk of encephalopathy from anoxic brain injury, because overdose is so frequent here in America especially, and that problem is only getting worse. And I kind of live in the very, very close to the epicenter of where America's addiction problems really began, surrounding the Appalachian Mountains. The differential for this problem of general encephalopathy is massive. When you were talking about that, I was curious, what is your opinion, or what is your more scientific opinion on why that herpes virus migrates into the brain? For those who don't know, HSV1 lives in the spinal nerve root, and it is totally dormant there. And when it senses any sort of chaos or stress, whether that be an illness or significant emotional stress, it may break out and travel down that nerve route to the lips and cause, what we commonly call a cold sore outbreak. But sometimes it, for some reason that I don't know, and I know there's competing theories about it, it will go into the brain as opposed to out to the mouth and lips. What's the kind of latest on that?
Yeah, good question. Look, I still think it's an unresolved question whether HSV predominantly causes it through this retrograde or backwards up the nerve mechanism into the brain itself, or whether the reactivation spills over into the blood system and goes to the brain. It seems it's likely that in adults and older children that the retrograde nerve mechanism is the predominant mechanism, but we certainly know that in young babies with primary infection with HSV rather than the reactivation, it can get to the brain through the bloodstream more generally. So, there might be some variability. Maybe the age is an important determinant of that, but we do know that it can be either or. My guess is that it's probably predominantly in older children and adults, that retrograde nervous transport mechanism.
And does that stay for the entirety of the class of herpes viruses?
So good question. So there's 8 herpes viruses, as you know. The first 3 of them are the alpha herpes viruses and are related biologically in several ways. That's HSV1, HSV2, and varicella zoster virus, or the chickenpox or shingles virus, which you referred to a little bit earlier. All 3 of those have this shared biology of infecting skin cells, but also nervous cells, and then being able to be transported in the nerves. That's quite different to the other herpes viruses like cytomegalovirus, Epstein-Barr virus, and then I won't go on about the rest of them. But those viruses predominantly affect immune or white blood cells and the white blood cell system in the body. But that system means that they can also infect almost every organ in the body to some degree. And they can cause viral encephalitis, but they tend to cause it mainly in people with immune suppression because of transplants or cancer, in contrast to the alpha herpes viruses, HSV1, 2, and VZV, that predominantly cause disease in non-immune suppressed people. So, yeah, herpes viruses are a fascinating family of viruses, and they have this. The other thing about them, of course, as you just described, is they can cause disease in the body at primary infection, but all of them have the characteristic that once you get infected, you never clear them from the body. They are latent or dormant and can reactivate in certain circumstances. So you can get disease with primary infection or reactivation depending on your immune circumstances and age.
What do you make of my friend having a C3 dermatomal rash the day after he got home from the hospital that just broke out? It wasn't itchy or anything. He didn't have any of the other symptoms of shingles, but he did have a dermatomal rash. It was funny because I'm trying to revamp my knowledge on this all through the weekend while he's getting into the hospital, and I'm looking up case reports and case series on different herpes virus encephalitis and varicella encephalitis. And one of the first case reports that I pulled up had the exact same dermatomal rash that he ended up having in that C3 area. What do you make of that? How much would that push you towards that being the causative virus in his condition that was, by the way, responsive to ganciclovir?
Yeah. So without committing to offer a diagnostic opinion about your brother-in-law over the internet, of course, which I'm wary of, what we do know is in some cohorts of particularly adult encephalitis, varicella zoster virus is one of the top 3 or 4 causes of viral encephalitis. So that's one thing. We know epidemiologically it's been shown to be a reasonably frequent cause of what's not a hugely common condition, but yes, a reasonably frequent cause. The second thing we know is if you take people with shingles, and you do a spinal fluid. I mean, I know we don't do this all the time, but there have been studies where you take people with shingles and you do a spinal fluid, you will see that virus reactivate in spinal fluid of a reasonable number of people who have shingles. So those two clues together tell me that varicella zoster virus definitely can cause brain infection, and that it definitely can cause brain infection or central nervous system infection with reactivation, not just with primary chickenpox. And so in that setting, it's reasonably plausible where somebody has a shingles episode in the context of a encephalitis that it could be causal. But by the same token, one of the reasons we'd be cautious about being certain about that is exactly the point that you made when you described sort of the herpes reactivation, and applies to shingles too, is that other infections and immune stimuli can trigger these viruses to reactivate. So it's possible it was something else. That stress, immune or otherwise, caused his shingles to reactivate as an epiphenomenon or parallel phenomenon rather than the cause. One of the ways you would really go about being sure of that is showing that it really was VZV reactivated in the CNS of in the CSF of him, if you had that sample. And even more plausible in some ways would be to show that there was a concurrent immune response in the spinal fluid as well. So we do that by testing for antibodies against that virus in the central nervous system at the time. And if you had those two things, they would be very strong evidence that it was the primary cause. You know, the other piece of evidence you've given is a response to an antiviral directed against that virus. Again, that's a weaker kind of form of evidence. Now, I'm giving you a very researchy type perspective on this,
it's good because we want to cast a wide net and make sure we don't miss things, and then kind of systematically knock things off that list. I would say anything bacterial is very unlikely, as he never had any sort of fever. Unfortunately, this is the American medical system, and this happened in late May, and they said the earliest follow-up he could get was mid-September. So he was hoping to have more answers at this point, but still waiting on follow-up. So, but that whole situation, I was described a person who had a lot of trouble sleeping for multiple nights in a row with a lot of anxiety at night, which was somewhat unusual. Then followed by the florid presentation of altered mental status. But it really strikes me because as a psychiatrist, it is something that, for example, many, many years ago, back in the teens and in 1920s, we had another diagnosis that was psychiatric that we didn't realize should have belonged to the field of neurology in syphilis. And syphilis used to cause a kind of a progressive altered mental status, more so over years, but we didn't realize that it was due to an infectious cause. So it went from a psychiatric condition to a neurologic condition. And that, to me, was always something I tried to keep at the forefront of my mind in terms of how history has played out, because, psychiatry, I absolutely do think that there are primary psychiatric conditions, and I also think that a lot of other things are medical that we are not able to explain yet. And so I think it's important to be open about all the things that could be going on medically. And as I progress through my career, I hope that we're able to lift the veil on some of those other conditions and really turn more psychiatric problems into neurologic problems. But what do you make of emergency room or psychiatric providers missing this diagnosis? I worry that if he was somewhere else, he may have had his diagnosis missed.
Yeah, I think we probably don't have a really good handle on just how frequent this occurs in terms of delay or misdiagnoses. There certainly are case reports and case series of people who ended up in psychiatric care who then went on to be diagnosed with a viral or immune mediated encephalitis, and in particular, there's one particular antibody mediated encephalitis called anti-NMDAR that has become a cause célèbre, if I can use that language, of this phenomenon. So, and that was really described in great clinical detail probably about 15 years ago, and then now a lot of research in that space. We've shown that a small proportion of encephalitis in children, viral or immune mediated, will present predominantly like a psychiatric illness with delusions or hallucinations or suicidality. So that proportion amongst childhood encephalitis is pretty small, less, 1% or less. But we have shown some of the features that tend to predict this amongst encephalitis as a whole. So the group of patients with more subacute onset presentations where they have those psychiatric features, but also there's a suggestion of seizure or there's a suggestion of fever. However, transiently, those things might be present. It's kind of those red flags in a psychiatric presentation. The other one is a complete absence of any social triggers or any prior psychiatric illness in somebody is a real red flag. Now, in psychiatry that completely new onset, psychosis does happen. And the younger you get, the more likely a new presentation is going to be something that will persist. But certainly, I think that psychiatrists should be thinking in any new onset psychosis or in any suicidal patient that doesn't have some situational trigger that can be discerned or some social risk factors, they're the patients who should be thinking, could this be something different? And yeah, look, I don't think it's that common. Amongst emergency doctors, again, I don't think we know exactly how common it is, but we do know from a survey that was done by an organisation called Encephalitis International, based in the UK, that if you ask emergency practitioners about symptoms of encephalitis and how often they would consider it as a cause, that anything between a third and a half of emergency providers will not necessarily consider encephalitis, even if they're presented with a patient with symptoms that could be consistent with that diagnosis. So, and that that's a survey, but it was a reasonably well sampled survey from Europe and the UK and Australia, and amongst the respondents, there was a lack of confidence and a lack of knowledge and awareness relative to what we would like to see. So look, one of the reasons we do these, one of the reasons I do these kinds of interviews, Ethan, and appreciate the opportunity, is to try to push out into the community as far as we can, because rare and unusual conditions are hard for the health system. There's no question about that. A lot of the way the health system is developed and practiced is geared towards high frequency, high burden conditions. And the unusual or the infrequent then gets kind of, let's call it, demoted, either by the funders or the administrators. And so the more that, we can advocate and call to mind these issues, both for the community as well as for health practitioners, the better, I think.
Yeah, and, I really think it's practicing a lazy form of psychiatry if you don't give serious consideration to medical causes. With that said, I mean, there were several attendings that, myself and my cohorts in residency had to educate a little bit on anti-NMDAR encephalitis or encephalitis. So it is definitely a newer phenomenon, but, I got so frustrated with again, what I just call lazy psychiatry. Somebody has a psychotic condition, they come on the unit, and you give them an antipsychotic or you give them a mood stabilizer without really, thinking, could this be something else? Or thinking after a few days of not responding to those, that's when you really should be thinking, especially like you said, in somebody with no history of any primary psychiatric condition, that, hey, maybe there is something else medical going on here. But could you give a little bit more differentiation between some, I guess maybe the most prominent types of encephalitis: acute onset, subacute, chronic, and then how maybe you would try to differentiate those clinically?
Yeah. So the timeline, which is what you've kind of intimated with the acute versus subacute versus chronic, the timeline is important with respect to cause, and certainly where you have very acute syndromes, they're more likely to be infectious. Where you have subacute syndromes, they're more likely to be immune mediated. The chronic encephalopathies or encephalitis are a very distinct group, really, and save for a couple of particular chronic infectious encephalitides, probably the most famous of which is the chronic form of measles encephalitis called SSPE. A lot of the others are still very much mysterious. The timeline is important with respect to cause. Another thing that's very important with respect to cause is age. So we know, for example, that even within childhood, if you're under 1, the causal spectrum's quite different from 1 to 5, is quite different from 5 to 10. And so being able to recognize these factors that are going to push you into a different causal spectrum is very important with respect to testing and early treatment. Quite a bit of work's been done in the immune-mediated space. So over the last, say, 5 years, there's some good clinical guidelines for the diagnosis of immune-mediated encephalitis in adults and children. And in particular, those guidelines are quite helpful because they've proposed features that are consistent with immune-mediated encephalitis that allow you to make treatment decisions even if you don't have a diagnostic test. And that's important for early treatment, but it's also very important for the 2/3 world out there that don't have access to a lot of the diagnostics that you might require to make these diagnoses. The other thing that we talk about quite significantly from an infectious point of view is trying to put together the risk factors in terms of exposure to certain infections in different locations and with different activities, with the clinical features, with the neuroradiology. And so we've written guidelines for Australia, there's international guidelines, there's guidelines for the US and the UK and France, and all of them try to help clinicians see that if you can understand the clinical presentation, including the timeline, if you can understand the range of risk factors for certain infections, if you can get the right kind of neuroimaging, a combination of those factors allow you to select a productive testing approach and hopefully land on a good diagnosis. But when we tried to study this in children just on the basis of clinical features and tried to see whether any specific clinical features could accurately predict cause, what we found is that there was no simple solution there. So it remains a challenging condition. There's no doubt about it. Quite a variety of presentations. Any single cause can present in a number of different ways. So it is still a big challenge for clinicians.
Are there certain viral conditions that are cause more often cause solely behavioral changes without any real focal neurologic signs?
Yeah, good. So herpes simplex 1, a minority of herpes simplex encephalitis, but an important minority, does present with effectively acute behavioural disturbance, often with speech disturbance, and no fever and no fitting. Even though it's not the most common presentation of HSV encephalitis, we would say HSV is one of those ones that should be on the list. The other reason it should be on the list is we don't actually have directed antivirals for many of the viral causes, but for HSV and VZV we do. and prioritizing those causes in people's minds that they can actually give a treatment for is very important as well.
What specific types of speech changes do you tend to see with HSV encephalitis?
Yeah, now you're pushing me, because when I see it, I normally see it in neonates who don't talk at all, right? So in pediatrics. But in adults, you can go anywhere from effectively what appears to be a selective mutism through to largely just dysarthria rather than a language problem. It's more a speech problem. But it can be quite varied. But some people in those circumstances will be misdiagnosed as stroke as the key differential diagnosis up front, because they present effectively with a transient ischemic attack-like presentation with dysarthria and sometimes confusion.
So, I have to point out here, this would be a psychiatrist saying this, but I really do believe that even in people's most psychotic or altered states, there are grains of truth to the things that they are saying. One thing that I left out is when he was in his altered state, he said multiple times that my skin is burning. My skin is burning. That was the other piece that really got me thinking about the VZV as the causal factor. But after, he had 2 rounds of ganciclovir and was not altered anymore, he was no longer saying that. So it was just kind of putting those puzzle pieces together, kind of like a investigation trying to figure out what is giving us more details about the condition versus what is just not at all relevant. But what about some of the longer term outcomes of patients, and how can you kind of decipher based on their initial presentation what type of long term outcomes they may have?
Yeah, good. We're in fact in the middle of a piece of work taking about 400 children that we have in our registry and looking at their outcomes at 12 months after their infection, which is again a piece of the research that we've done, and trying to say, can we discern from their acute presentation factors that predict their 12-month outcome? So that's in progress, but the long-term outcome of encephalitis in children in a high-income setting, very different in low and middle-income settings. But in a high-income setting, about 1 in 20 children die from their illness. Adults, it's about 1 in 10. In terms of the long-term outcomes, if you think about it in terms of complete recovery, in children, about half of children who survive will completely recover. Half will have some sort of difficulty. And in adults, it used to be thought that the full recovery was maybe a bit more frequent, but actually more and more it's looking like it's very similar. Maybe half to 60% have some level of ongoing difficulty. And amongst those with ongoing difficulties, it's split, in children, about a quarter will have a severe brain injury, essentially, whereas about a third will have essentially subtle neurocognitive or learning problems, but will substantially be able to function. And in adults, that more subtle end of the spectrum manifests mainly as inability to return to, say, work or study. And that was almost entirely unmeasured until maybe 5-6 years ago, where people have more accurately tried to look at that. And it may well be that 2/3 of adults who survive their encephalitis have some level of problem. And the biggest group are people who have some level of persistent personality change that affects their relationships, or some level of inability to return to their level of work that they used to do before. So this is a very burdensome condition over the long term. If you look at what predicts that, as I said, we're in the middle of a piece of work, so I don't have all the answers yet, but across the broader literature, the level of consciousness impairment acutely, the need for intensive care management, just how much of the brain is affected on neuroimaging or on EEG, which is a different measure of brain function, all of those things likely predict long-term outcome.
So if you knew you were going to contract encephalitis and you could set out in advance the most important treatments after the acute phase of your illness, what kind of things would you set out for yourself to try to be in that third to half that make a full recovery?
Yeah. We think that all people who've had encephalitis should be assessed reasonably closely across the first 12 months from their illness. Now, of course, all different health systems, as we've talked about, have different, resource capabilities and opportunities, but we would say that you should probably, as a minimum, be assessed about 3 or 4 months after you've been acutely unwell, and then at 12 months. We know that the recovery from a brain illness like encephalitis does continue to occur across a 12-month spectrum. So what you look at discharge is not necessarily what you're going to look like at 12 months. But what you look at about 3 or 4 months is giving you a bit of a sense of the trajectory of that. So understanding that you do have to be followed up across that time frame, and understanding that effectively what you're hoping is full recovery, return to base level of function, so that when you're not doing that, it's really important that that is brought to the attention of people as early as possible. Not necessarily because they're going to be in a position to have a treatment to, fix your problem. But what we do know about rehabilitation overall is function is king. And if you can identify a problem as early as possible, what you can often do is provide the kinds of therapeutic inputs that allow them to build scaffolds into their life to achieve some level of resilience with that level of function. And, I'm speaking to a psychiatrist here, but when people's function is impaired and they aren't offered a rehabilitation pathway, even if that is just to provide resilience through scaffolding, they are much more prone to then deviate into comorbid mental health issues that can then become actually, let's call them mutually reinforcing. You don't do things because you don't think you can do things. You get depressed, which means the people around you find it harder to deal with you. And in fact, that's often the saddest story, is people who have not had minor, relatively speaking, functional problems identified and then offered ways to rehabilitate that, find themselves then out of work, poor mental health, relational breakdown, and then really what could have been deviated into a more constructive approach to rehabilitation has not happened in that 12 months after illness, and then you've lost an opportunity, and often you start to get into trajectories being much more entrenched.
Is there any research or data that you're aware of on the rapidity of early treatment in predicting long-term recovery?
No, not very much at all, actually. So a lot of there's very few good controlled trials in encephalitis, right? There was a whole bunch to show that antivirals worked for herpes simplex encephalitis, and then since then there's actually been very little. And all of those trials were very much focused on acute survival. So can we give a treatment that can reduce the mortality rate? And then there's been a real stagnation in clinical trials to then look at what does it look like to optimize those therapies, and then what does it look like to then move into that tertiary prevention space of saying, okay, you've survived now, but what does it look like to have interventions that optimize your functional outcome? So I'm sad to say there's been a dearth of really good quality evidence for how to manage this. So in fact, a lot of what's done for encephalitis is leveraged off evidence for other forms of brain injury, either traumatic brain injury or stroke. And so a lot of the models for rehabilitation are modelled off those areas rather than based on direct evidence in viral encephalitis. Now I think there's good plausibility for that, to apply that evidence in that way, but it's not perfect. Yeah.
Well, I mean, it certainly makes logical sense that if you have the onset of symptoms and a day later you get the appropriate treatment and have resolution of the symptoms, that it would be more likely that you would have a benign long-term course. But obviously, we would like to see that play out with more official data and research. Unfortunately, it is something that is recognized as a rarer condition, and therefore most research is funded by some branch of the pharmaceutical industry, or I would say at least the majority of it. So maybe if we talk about it enough, then and it becomes enough of a in the public health's awareness, then there may be better information on it.
Look, there are. I would want to say there are some islands of excellence really in this area. So there's a fantastic neuroinfections group in the UK at Liverpool University who've done some great work. They've just completed a trial looking at giving steroids in addition to antivirals for herpes simplex encephalitis. Those findings will be coming out soon. There's been a huge amount of work in the antibody-mediated encephalitides to show that not just that immune modulated therapy works, but they've starting to really develop pathways of how do you escalate it and in whom. So there's some great work going on out there. I don't want to suggest that there isn't, but the direct answer to your question is, do I know that if I give X treatment at X time point that it's a big game changer, except for having, that it seems to make, good sense and that we wouldn't want to do otherwise. I can't tell you that I know for sure. Right.
One of the interesting parts about the overlap of this with psychiatry, I feel like most of the drugs that we have in psychiatry are hyped up more than what their results actually show. We have dozens of neuroleptics and dozens of antidepressants, and the effect sizes of all of our drugs are not that great. There's one drug that is very, very intriguing to me. I've talked about it a lot on the podcast, and even in low doses, I think can have really incredible ancillary benefits beyond mood and suicide prevention, is lithium. And we've known for a long time in bipolar patients, back to the 80s and 90s, gentlemen, J.D. Amsterdam and Janis Rybakowski are a couple of researchers that have been looking into this for a long time. They and their patients noticed that the ones on lithium stopped having cold sore outbreaks, and the ones not on lithium didn't have any change in the frequency or severity of their cold sore outbreaks, which, again, just to reiterate, are related to a HSV1 or, if you have an outbreak in the genital area, HSV2. I am always a big proponent of read as much research and data as I can, but I want to see those same conclusions that are drawn in the data. I want to see those play out in my own patient populations to really bolster my confidence in that assertion. So one thing that I did about 3 years ago is I just started taking an extremely low dose lithium supplement, And probably throughout medical school and residency, I would have 1 to 2 7 to 10 day cold sore outbreaks, usually at a period of time when I was got some sort of other illness or was very, very stressed. About 3 to 6 months in, I have not had an outbreak since. What is your familiarity with the, lithium's ability to directly inhibit the replication of that herpes virus? And do you think that there's any promise in treatment in an acute setting, or maybe long-term supplementation as a prevention measure for certain types of encephalitis?
So, in Australia we play cricket, not baseball, and in cricket we would say that's a question that I'm going to let go through to the keeper, because to be honest with you, it's an intriguing thought, Ethan, but I don't have any good additions. But the idea of neuroactive agents potentially being repurposed as anti-infectives, I mean that's happened on more than one occasion. So I'm not against the idea. I'm open to the idea. I'm intrigued by your story, but I actually don't have any decent thoughts to add at this point in time.
Well, and like you said, I mean, the patients with means have much better outcomes with this conditions. Patients without means have much worse outcomes, and that is at least a promising treatment that is extremely affordable, that certainly does have promise. I mean, and it's not just the herpes class of viruses. I mean, there is newer research on lithium and COVID, and so it may not just be this direct antiviral effect, which we've known about lithium with, also like the HIV virus. It may also be a way to kind of bolster the immune response, but then also turn down the immune response, be an immunoregulator, so to speak. So I don't know if who's going to pay for that research, though, because I prescribe, the lowest prescription dose to my patient for 90 days without insurance, and it costs them $8 or $9. So, but it is an interesting potential treatment, especially in lower income areas with less medical care available to people. On that note, what about you? What are you most intrigued about in the research area or treatment area regarding encephalitis right now?
Yeah. So the area that I've narrowed in a little bit on is these, what I've called infection-associated encephalopathies in children. So they're the ones where the virus infects the body, causes an inflammatory response that affects the brain, and it's an indirect process because the virus doesn't go to the brain. So the kind of typical cause of that is influenza. And that story that I told you at the start about that little boy who died so abruptly and tragically, he had influenza that caused his brain disease. And these disorders were originally described in Japan in the 80s and 90s. For a long time, they were kind of largely ignored outside of Japan. And then really from the early 2000s, it's become pretty clear that even though they may be more common in Japan than other parts of the world, they happen all over the world. And amongst the children that I see with viruses causing severe brain disease, these influenza or infection-associated encephalopathies are the worst. And so we've been trying to really start to do some of the groundwork to move towards clinical trials, at least to set up a paradigm of doing clinical trials for the management of these conditions. And we're partnering with colleagues in Australia, across Australia, both in neurology and infectious diseases, and trying to come up with some good but health system embedded and pragmatic approaches to trialing therapies for these, and hopefully in the process understanding them better and getting better data and samples. And so that's what I'm I've kind of narrowed in on, and the reason I've narrowed in on these is at the severe end of those conditions, the acute mortality rate is more like 30 or 40% rather than 5%. And the long-term outcomes amongst survivors, it's more like, 70, 80% will have some level of long-term brain injury. And amongst those, some will be very, very severe. So it's really the burden of those disorders that have got me to narrow in on those. They are totally intriguing too, because how does an infection that doesn't go to the brain cause severe brain injury, and through what pathways? Well, that's one of those things that we're trying to do some work towards figuring out, as are many of my colleagues around the world.
Yeah, and you may blow the doors off of a lot of other scientific or medical or neurologic questions if you can find the answer to that as well.
Yes, and that's one of the great things about working in research and science, is sometimes the important findings are actually serendipitous. Yeah.
Yeah, absolutely. I would say a significant portion of the time they're serendipitous. We're looking at one thing and we figure something out that is totally unrelated. But before we kind of wrap up here, I'm just curious. So, outside of your clinical work, outside of your research work, tell me a little bit about your personal life. What do you do to get away from all of your work? How do you reset? How do you, stay fresh?
Yeah, good. So look, I'm a father and a husband, and I've got a pretty busy life when it comes to what's going on for them. Try to keep fit. I run, I swim a few times a week. That's good. And I have a completely parallel interest in clinical medicine, which is clinical ethics. So at the moment, as well as my infectious disease role and research life, I'm actually doing a master's in bioethics at the moment, and I'm in the middle of political philosophy at the moment. So they're my other interests. They are very, they interface with the clinical medicine world, but also there's a lot of interesting areas to explore that have nothing to do with what I do in my day job, and that's what's great.
Absolutely. It sounds like you have a lot going on. I know how much it is just to try to manage this podcast with my clinical work, with my two small children, and make sure and still make time for my wife and family and other friends. So I would ask you about to give us some perspective with the class you're taking on our current political circus that we have going on here with the election coming up, but that may take another hour. And I understand it is pushing 9:30 for you, and with kids, you got to find a way to get into bed early because you're going to be up early no matter what. That's
right. Look, I could say all sorts of things about politics at the moment, but I think we'll call it a day, huh?
Absolutely, absolutely. Well, thank you so much for coming on and educating me and my listeners a little bit more about encephalitis. And now when I use the term encephalitis with my colleagues, I will point out to them that it is the more appropriate way in terms of the origin of the word to say it.
Well, there you go. I've had one win today then, haven't I?
There you go. There you go. All right. Thank you so much. And hopefully I'll get to talk to you again at some point in the future.
Good on you, Ethan. Thanks very much.
See ya. Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.